Patellofemoral joint dysfunction. Okay, you know, obviously we're talking about runner's knee. Today I'm going to bring you a bit of an overview on how to assess and how to treat this really common injury that we see in our runners. There's no doubt about it. It's not just runners that we always see it in, so keep in mind that you can apply these techniques not just to runners. It could be even cyclists or even soccer players or golfers or whatever the case may be, but it is mostly common seen in our runners. Patellofemoral joint dysfunction, it is basically a bit of an overuse injury. The beauty of these techniques that I'm going to show you today is that they really are quite valuable and they really do make a massive difference really quickly. The overview will be on treatment procedures to a series of muscles. So the first one will be the rectus femoris, which plays a big role in terms of pressure onto the actual patella itself. Then we have the vastus and medialis, so the battle between the patella tracking issues that we see. We also focus on the popliteus muscle, once again biomechanically has a big influence on the knee itself, and also the biceps fem, and especially the short head, which is really important and often missed when dealing with this sort of condition. Keep in mind that the patella tendon often coexists with this dysfunction as well, so keep in mind that we need to palpate those areas as well. Now, before we go anywhere and talk about the knee, we absolutely 100% have to clear the hip and the lower back when we're dealing with these injuries, because that is the starting point for any of these lower limb injuries, okay, and even when we start dealing with calf and leg issues. So it is important that you focus on clearing the hip and any of those restrictions in and around there before you even start to attempt to look at the knee itself, okay? I can't really emphasize that any more than this, especially if you're dealing with runners as well. I think also when we're dealing with the knee, it's important to know that there are other conditions that can create pseudo pain in and around the knee, so we also need to be aware of those. We've obviously got a bursa that lies underneath the tendon of the patella, so that can also be coexisting as well. Also, we need to rule out if there's any intra-articular problems with the knee as well, so God forbid there's any meniscus injuries, or God forbid we've done a problem with obviously one of the stabilising ligaments of the knee, but these will all be involved in trauma, so not like your overuse, which is what we tend to see these injuries are. Keep in mind that also, once again, when we're dealing with these techniques, it's practice makes perfect, so make sure that you take the time to watch the videos, then apply it, and it will take a little time to get used to these techniques, but trust me, they are invaluable in terms of treating this type of dysfunction. So let's look a little bit at the knee anatomy itself so we know where all these structures are. So obviously when we start looking at assessment and also when we start looking at treatment, we know which structures are what. Okay, to start with, let's have a look at the outline here. This will obviously be the outline of our patella, okay, itself. Okay, running off that patella will be the patella tendon, which comes down and attaches onto our tibial tuberosity, which is basically that really big bump there on the front of your tibia. Now, if we go out to the lateral, then obviously we'll have the lateral joint line here, okay, and then coming down on the lateral also we have the ITB as well, which comes all the way down here and basically attaches onto Gertie's tubercle. Okay, we've also got the bulk of the vastus medialis all under here, so it's a large muscle, makes up a big part of this lateral part of the thigh. Then we have rectus femoris coming down here, okay, so we have the suprapatellar up here and obviously the infrapatellar there as well. So we can obviously have tendon issues on both ends of this patellar area. Now, if we come from the medial, obviously, as I mentioned before, you've got those three muscles that attach in here. But for today and what we're looking at, especially with patellofemoral joint dysfunction, it's so important that we focus on a lot of these lateral thigh muscles and the lateral structures themselves. This lateral joint line here, you've got to keep in mind that there is a retinaculum in and around this area as well. So it's a thick band of connective tissue. So that sometimes that actually gets quite restrictive, and that can add to a little bit of the patellofemoral issue. So if we're talking about the actual mechanics and the pathology of patellofemoral joint dysfunction, a lot of the time it is basically a patella tracking issue. Okay, so there's no mystery to what happens here. Unfortunately, what will tend to happen is these lateral thigh muscles will become quite dominant, and because the patella is embedded into the rec fem itself, what happens is it tends to just be pushed or dragged out laterally, okay, which basically means that the patella then starts to articulate unevenly in the condyles there, and that's what will give us classic retropatellar pain. Okay, so that's pain that is underneath the kneecap itself. Okay, and it is really poorly localized, so it's very difficult to try and reproduce the pain because it's underneath the kneecap itself. Okay, so that's your classic retropatellar pain. If we move away from there and then obviously we look at patellar tendon pain, that's really quite easy to assess too, because obviously just pressing down on the tendon itself and running backwards and forwards over it should reproduce a lot of the pain they have. But unfortunately with the patellofemoral, that issue is because the pain is under the kneecap, it makes it that little bit more difficult, and that's why a simple leg squat will more than likely reproduce that pain. Or what we also can do is just press down over the top of the patella and then glide it medially and also laterally, and what you'll tend to find is that can also reproduce their pain, okay, because then you're pushing those surfaces that are unfortunately irritated, and that should reproduce a lot of their pain. Okay, so patellofemoral pain, because it's diffuse, a lot of the time, sometimes it can be down here in that sort of infra area. Sometimes it's out in the lateral, sometimes it's the medial, and sometimes at the top. So it varies from person to person, and it will vary from your athletes, your track athletes, to also your athletes that potentially that might obviously once again change direction, so they may see it more in the medial than the lateral. Okay, so now that we're looking at the treatment of patellofemoral joint dysfunction, the number one thing that we want to do here before, obviously I've mentioned beforehand to you that the hip plays a massive part in terms of determining how important it is to get resolution with these patellofemoral joint dysfunctions. So the hip is obviously a prerequisite straight away, there's no doubt about it. But when we start looking at actually treating the knee itself and the structures to the knee, rec fem is the first place to work from. So we're going to look at obviously trying to take any tension we can in the rectus femoris, because what that does, if it gets tight, it will compress basically the patella onto those condyles underneath. Okay, now I see this a lot in a lot of juvenile, so young junior athletes who come in with patellar tendon pain. Okay, and it's not true patellar tendon pain. What it is basically a really tight rec fem, which obviously presses the kneecap down and obviously puts a little bit of extra load onto that tendon. So it's actually really easy to rectify quickly, and that is by doing some release work that we're going to do now with this rec fem. So let's just have a look at where we are with our anatomy. We'll just get you to push up against us there, Isaac. So now we can see some beautiful anatomy here because he's got some great definition. So look at this rec fem coming down here. He's got a massive vastus medialis there for a 1500 metre runner, and obviously we can see the bulk of our vastus lateralis there. Okay, we've got the ITB running down here as well, so we know where all our structures are. All right, we'll just get you to relax there. So this release technique, for those of you that are familiar with the hip protocol, you'll know that I do a passive release technique for the rec fem, and this is the same one, except the difference being here is we're going to add a little bit more load into this as we release this rec fem, because obviously we want to take as much tension as we can off this patella. So really easy. Now what we're going to do is we're going to come in with that, obviously the forearm, we're going to bring all the tissue back and across towards the midline of the table. Okay, so this is how we engage this tissue, so drag it all the way back until it will not go any further. Then take up all the skin laxity as much as you can and push up towards your client. So obviously we're looking at pushing up towards the hip. Now you're well engaged. Okay, so from here we then just apply a really firm purposeful load up along the length of that rec fem. Okay, so keep in mind that the knee needs to be in 90 degrees flexion or thereabouts, because we want the muscle on a stretch, because we're looking at lengthening and taking out as much tension as we can there. Now I'm obviously using the cream in terms of the Premax, because obviously I don't want too much slip in there. Just want just enough. If I use the lotion or an oil, I won't be able to gauge this tissue the way that I want. Now, as we work up towards the insertion up here, what we'll find is that there's a trigger point here that sits basically right in that musculotendinous junction of the rec fem. Now that is important because that refers straight over the top of the kneecap as well. So that's an area we want to sit on and wait for it to dissipate and treat that trigger point as well. Okay, so the second step in this treatment process will be to focus on this vastus medialis, and as we saw before with Isaac, he's got a really healthy vastus medialis here. We're going to stay in the same position, okay, so we're going to have the knee still in flexion, obviously nice and relaxed, but all we're doing now is that because we're picking up this vastus medialis, what we're going to do is we're going to actually drag the tissue back towards the lateral, okay, and then we'll lock down on that vastus medialis there, okay, and we will strip along the length of that vastus medialis. Now this looks quite simple, but there's a bit of an art to it here, because what will happen as you come up to this vastus medialis, it basically will blend out and then you'll come right up against the rectus femoris. Now, it's important that you don't just roll over it, okay, which is what does tend to happen. I've seen a lot of therapists over the years do a lot of work where it flicks over that rec fem, and that's not ideal, okay. So we want to be really purposeful, and in terms of our direction, we're going to place it all onto that vastus medialis, like so. Now there are two trigger points in vastus medialis, which once again they are important, but from the point of view of dealing with patellofemoral joint dysfunction, those trigger points, they play a role, but not a massive role. So we can focus on those. So you'll have one down here, basically in the lower half of the belly of the muscle, and another one coming up towards that rec fem insertion. So, you know, if we think about the vastus medialis as like a big teardrop, that's the shape of the vastus medialis. So obviously as we come up towards, you know, the top of that teardrop, obviously we want to blend off there, okay? And if you blend off, obviously you're going to have the adductor group here, and obviously you've got the rec fem obviously on that lateral part of it, okay? So coming in, drag across to the lateral, okay, and then along the length of that vastus medialis, okay. Now remember, the vastus medialis and the vastus lateralis play off for basically that whole patella tracking, okay. So it is important that we do a bit of work on here, but obviously our focus is going to be a lot more on that vastus lateralis because that's where we're going next. So now let's go to what I classify as step 3, and that's going to be, we're going to look at this vastus lateralis muscle here, okay. It is a massive muscle, there's no doubt about it, and obviously it encompasses this whole area here. To the posterior, then obviously we fall into the hamstrings there. So if I push this up here, you can see almost the outline of that vastus medialis there. So yeah, it's a massive muscle. It has many trigger points. The ones down here in the inferior, so there's 4 basically in and around this area here. These trigger points here are responsible for a lot of this patella gliding over to the lateral. So that definitely is an area we need to focus on, okay? Now one of the ways that we can do that is coming in from this direction. Now because there's 2 in the anterior and there's also 2 in the posterior, we can use once again a really broad approach to it, okay? So that way we can work the whole area or the whole zone if you like. But keep in mind that the ITB comes down here as well. So we don't want to sit just on that ITB. So where we want to snuggle ourselves in is just anterior to that ITB. So it's really, really important. So what we're going to do here is we're just going to roll, obviously, the leg in a little bit medially, so that what that'll do is just give us a really good advantage point here onto these trigger points here. So I'm just going to come in this way here, and once again I'm just going to set down using that broad forearm so I can find the rec fem on one side, and if I come back then I can also feel the ITB. So I want to be snuggled in between those 2 there, okay, and then I want to sink down into that area there. Can you feel that, Isaac?
certainly.
Yep, you can feel that. So this is a really broad area of tenderness, okay? Now what we want to do here is just sit on this area here with these trigger points and just wait for that whole dissipation and that melt component, all right? It's really, really important. So we can also roll back a little bit more to the posterior, we can go a little bit anterior, we can come inferior, and we can also go superior. So we want to explore all of those options. Now once we start to get a dissipation there, so that all starts to just basically fade out, if you like, then we can come back and then we can start to do a lot more release type technique. So we're just going to sink into that tissue. Now this is really important. I break this up into parts in terms of this release because it's so important that we really engage this tissue and try and lift and offload this vastus lateralis. If you drop too far posterior, then you're going to massage or you'll be right over the ITB. I'm not a massive fan of massaging the ITB. I find it usually probably just creates a lot of pain without really any therapeutic change whatsoever. So you can see the speed that I'm traveling at here. That's about where you want to be working at, okay? Anything faster than that, then you're not going to get the desired release that you want. Okay, so I can break that up now, come up again, re-engage, okay, making sure that the knees roll into that medial and I'm focusing directly on that vastus lateralis. Now, as we come up to the mid portion here, we've actually got 3 trigger points that sit in that area there. So what we can do also is if we hit those there, then we can sit into that area again, take the same process again. Okay, so we can basically sit there, wait for them to deactivate. Once they have, then we move on to the rest of the actual vastus lateralis. Now, keep in mind this vastus lateralis comes all the way up here and basically blends in to all the fascia that then attaches onto the greater trochanter. That's exactly right. So coming all the way up here, and then basically what you'll find, if you keep going up towards the hip, you may find yourself rolling onto the tensor fascia lata. Okay, so come in with a loose fist if you like, or the forearm, either way, as long as you're engaging that tissue, purposeful, and at the same time with the same sort of speed. Okay, because it's all about releasing as much tension as we can through this vastus lateralis, because that's going to allow for obviously this whole patella tracking to basically normalise. Step 4, we're going to look at the popliteus, one of my favourite muscles in the body, primarily because it gets missed so much. Okay, it's a unique muscle. It actually unlocks the knee when we stride. So as you can imagine, it's pretty important when we talk about runners. Now, to find it, the trick is to find the condyle, okay, of your tibia. Come down, basically draw a line right across from that lower inferior condyle of the tibia. And then obviously you'll find the medial border of the tibia itself, and if you sink down into that tissue there, right at the back if you like, or the posterior, then you should basically find yourself right over the popliteus. So it's only a really small area that we have to play with in the popliteus, and basically right in the middle will be the trigger point. Okay, so it's actually quite simple to find once you know where you're going. Okay, so the reason that we use a side lying position is because this will give us the greatest access to this trigger point. You may find out there on the wonderful wide world web that a lot of people will come in from behind. Now, if you keep in mind that coming from the posterior, you actually have to navigate all the way through a lot of this tissue here. So the bulk of the gastro and also a little bit of the soleus, which it's not ideal. And, you know, obviously for Isaac, he's got quite a large gastros. So we don't really want to be trying to push all the way through to engage that. So obviously that's why we come from a side lying position. Just a lot more easier access. Okay, so we're going to come down, going to find that, basically that ridge, if you like, of the tibia. I'm going to roll off that okay, and then into this like small, almost sulcus area, if you like, okay, and then you're basically just going to use the border of the tibia to run along, and then you'll sink into that tissue there. So basically right into the popliteus, just about there. How's that feel there, Isaac?
Okay.
Yep. So it's a distinct sort of feeling. It will be very, very tender on a lot of the athletes or your clients that have not had this work before, so go a little bit easy. Don't have to absolutely annihilate it. So once you find there, so I usually find just a little bit of just longitudinal gliding and stripping through works just perfectly for this popliteus, okay? Now, it actually comes around and wraps around and inserts basically into the lateral part of the knee. Now, it is debated in some areas, especially with some of the anatomists and so forth, that it can insert into the actual meniscus itself, but I'll leave that up to you guys to debate. But nevertheless, it is important because it does unlock that knee when we stride, so that obviously changes the game and the biomechanics of the knee, especially when we're looking at patellofemoral or patellar tendon pain as well. Okay, so we've turned our clients over now because we're now going to have a look at the wonderful biceps femoris, so it's part of the hamstring group. Now, the biceps fem is important, as you well know, obviously because it plays a part as being that lateral hamstring, but it's the short head of biceps fem that I'm actually most interested in. There's a beautiful little trigger point in there that plays a big role in terms of, once again, like popliteus, but it can change a little bit of the biomechanics of the actual knee itself as well, and it often gets missed. So the short head of the biceps fem. So let's just quickly have a look at the anatomy, and I'll just get Isaac to contract against me here, and you can see he's got wonderful anatomy here. This is fantastic. So we can see the biceps fem coming down here. So it's sort of in between here that we're going to hit that short head of biceps here. So we're going to have to push, obviously, the bulk of biceps fem out of the way and then sink down into that area there. Righto, get you to relax there. So we will bring the leg up, because what that does is it softens off the tissue here and allows us to be able to sink into this tissue here, okay? Once again, we're going to use the forearm. So I'm going to come into the edge of that biceps fem, obviously just bringing the leg up to soften off that tissue, coming down, and then I sink in basically with almost the point of my elbow, but not too much so I blunted it off, because I have to push the biceps fem a little bit out of the way and hook straight onto the short head of the biceps, which lies straight onto the femur itself. Now, this is a digital ischemic pressure, so we're looking at just hitting the trigger point in this area here. So we sink in and just basically hold it, and obviously we're looking for that whole dissipation, we're looking for the melt, and we're waiting for it to just basically just really relax, because in terms of trying to massage this area, it makes it very difficult to get in between the bulk of the biceps fem itself, okay? So that's why we use this sort of digital ischemic trigger point type technique. And we're just looking at, yep, waiting for it to dissipate. We can sink up, backwards, obviously we can lateral to medial, inferior to superior, all of those areas, and explore that tenderness there. Okay, so the next step in this lateral part of the knee is looking at actually releasing the lateral retinaculum. Okay, so we've already targeted these trigger points here in the vastus lateralis. Now it's time for us to come down and pick up this lateral retinaculum. Now, as I've mentioned, it's so important that we release all of these lateral structures here, so we can allow, obviously, that balance between that vastus medialis and vastus lateralis. Okay, now this is a technique that I've developed over a period of time, and it works an absolute treat for releasing the fascia of the lateral part of the knee. So I'm going to pick up the edge of the patella itself, and I'm going to drag all the tissue down until it won't go any further. Now I know that I'm engaged onto that fascia, especially that lateral retinaculum, and I'm just going to put a really broad pressure through our thumbs, down and along and over the condyles. Okay, come down a little bit further. Same again, take the laxity out. Be purposeful, push all the way through and just really open up that lateral retinaculum. And you can work your way all the way down through this lateral part of the knee. Okay, so if you haven't done this before, keep in mind that if you put too much cream on this area here, then you might be slipping and not engaging properly, so that's not ideal. So just the right amount of cream or lotion through that area. Probably use the cream more than the lotion. All right, now we do have 2 trigger points, okay? One in basically the superior tendon of the patella, and then one in the infrapatellar tendon. So these are also awesome little trigger points as well, especially for releasing a lot of these patellar issues as well. So what we're going to do is I'm going to bring my hand underneath, okay, the thigh itself, and then I'm going to come across the top here, and then I'm basically just going to lock straight down over onto that, basically the superior patellar tendon, okay, and there's a trigger point just nestled in that area there. Now once again, this is a digital ischemic pressure again, so once again it's one of those techniques where we're just waiting for the trigger point to dissipate, and we're waiting for that sort of release technique as well. So we sit on there. Sometimes it might take maybe 2. If it's someone who's not really had it done before, it might take 3 minutes. So obviously you want to be in a position that you're actually quite comfortable. Like any of these release type techniques, obviously we're looking at working with the body. So if you push too hard, obviously you're not going to get the release, because obviously people are going to fight against you, okay? So there's the supra. If we come down, there's another one here into that infra, okay? So we're going to come down, lock down onto that, okay, like so. And once again, we're just going to wait for that to dissipate there as well. Okay, so infra and obviously the supra, and releasing the lateral retinaculum. Okay, let's look at actually taping for patellofemoral joint dysfunction and also patellar tendon. All right, so you're going to need 2 pieces of tape. We're obviously using the Kineso tape. Well, this is rock tape, obviously. So quite simply, what we're doing here is we're going to basically lift the kneecap and obviously bring it over to that medial, obviously because we have a lot of that lateral tracking. So we're going to need just a really small strip here. I'm going to split in the backing tape like so, okay, and this is going to be our decompression, okay. So we're going to come just below the inferior border of the patella, okay. So we'll put this on a stretch of about 80 or 90% of the full capacity, and then just lay that down like so. No tension on the ends of those pieces of tape. That is very important. Okay, now we've got a second bit of strip. So obviously we've put a cut through the middle of it, and coming about just short of an inch from the top there. So now basically what will happen with this piece of tape is that one's going to wrap around, one tail will wrap around the medial, one will wrap around the lateral, okay. We want the split to be about, say, roughly around about 3 finger widths above the actual top of the patella, okay. So there are our landmarks there, and basically we have the rest of the anchor, if you like, which is the very top part of the tape itself. So once again, rip off the top part of the backing tape, okay, and then we're just going to put it, as I said, about 3 finger widths above the top of the patella, and that is to the top of the slit itself, okay. Now the medial head, or the medial strip tail, we're basically going to be at around about 40% stretch, okay. So we wrap around the border of the patella like so. Now the lateral obviously is going to be a little bit more, because we want to bring the kneecap a little bit further, so we put this one at about 60, okay. And if you do this right, basically what you'll see is this tail will be slightly longer than the medial, and that's what we're looking for, because we're lifting and just bringing it slightly over to that medial.